Welcome, everyone. We're going to give you a few seconds to just make sure everybody's getting on and technology is moving forward. But I do want to just say a big good morning and bienvenidos. For those of you who want to continue in English, stay put.
Para las personas que desean escuchar la versión en español, por favor de elegir el idioma oprimiendo el botón en forma de círculo, donde dice español en la parte inferior de la pantalla. Gracias.
So I'm Julie Chronister. I'm one of the hosts of our webinar today. So first things first, a brief audio description of myself. I'm a white cisgender female, she, her. I'm in my early 50s with light brown shoulder length hair, thick black rim glasses, and I'm wearing a black top and my background is blurry. I'd like to also acknowledge that SF state campuses in San Francisco sit on the ancestral homeland of the Ramaytush Ohlone. We further acknowledge that we work on the ancestral lands and waters of many other indigenous peoples and nations in our fieldwork in the Bay Area and around the world. We're also very committed to ensuring this webinar is accessible to our audience. Closed captioning is available in the closed captioning option at the bottom of your Zoom screen. If at any time your access needs are not met or become not met during the webinar, please send a chat directly to a host or co-host. Access is always a work in progress, so we appreciate your comments, feedback, and support. A bit about me, I'm a faculty member in the Department of Counseling, the Clinical Mental Health Counseling Program here at SF State. I'm the primary investigator on this project. I'm working alongside my project co-investigators, Dr. Tiffany O'Shaughnessy, who is faculty and coordinator of our Marriage and Family Therapy Program, and Dr. Molly Streer, faculty in our School Counseling Program. I'd also like to thank our graduate assistant, Christina Cabilas, who is working hard to stay on top of the technical issues today, the chat boxes, and the Q&A. This is our third of 10 webinars sponsored by our Equity and Justice-focused Integrated Behavioral Health Counselor Training Project, which is fully funded by the Department of Health and Human Services, Health Resources and Services Administration as part of an award totaling $1.9 million. A couple things before we begin. If you are one of our HRSA stipend recipients, i.e. student in our program, or you are interested in receiving continuing education units for your attendance today, please pay close attention to the announcements provided in the chat for sign-in and evaluation links. Just a reminder that this is a live recorded Zoom webinar. Therefore, the audience is not visible and the audience cannot turn on their video or audio. The chat function is available for comments and sharing resources, emojis, but to ask the presenter a question, please post your question in the Q&A function. Question and answer will occur during the last 10 to 15 minutes of the webinar. So please post your question there as your questions emerge. And I will, or another host will ask the presenter the questions. If we cannot get to all the questions, please contact the presenter directly. The presenter's information is posted in the chat and on this PowerPoint. So it is with great pleasure that I introduce today's presenter, Deena Lahn. Deena Lahn is Vice President of Policy and External Affairs at San Francisco Community Clinic Consortium, where she works with local, state, and national partners and policymakers to advance the interest of community health centers and their patients. Previous jobs included leadership roles at the Children's Defense Fund, the Child Care Law Center, and the Emergency Services Network of Alameda County, all of which involve policy advocacy on behalf of low-income people. Deena has also taught health policy in our SF State's Community Health Education Department. Deena has her BA from Yale, her master's in social sciences from University of Chicago, and specialized training in community healthcare from UCLA Anderson School of Management. I will now hand it over to Deena.
Hi, everyone. As Julie mentioned, I'm the Vice President of Policy and External Affairs at SFCCC. Just to explain SFCCC a little bit, we are a collaborative of the 12 nonprofit community health centers serving that are located in San Francisco. We actually serve people from throughout the region. That includes clinics like Northeast Medical Services, which is originally in Chinatown. We have Mission Neighborhood Health Center. We have the Native American Health Center, which has a large office in Oakland and a small clinic in San Francisco, Curry Senior Center. We tend to serve a very low income and very language and culturally diverse population. And so the consortium is where we all come together to try to advance our work. Most of the clinics are so busy doing the day-to-day work that they don't have time to do policy advocacy, which I'm going to talk about later. So basically, I work with them to get it done and to learn what their needs are and to carry them in the local, state, and federal level. We have monthly policy meetings where we discuss our priorities and a lot of communication in between. So we're kind of the go-between in some ways, with a lot of participation from our members between the federal, state, and local governments and the actual clinics themselves. I also just want to mention that I'm going to give some examples later in my presentation that are examples of policy advocacy work I've done. I just want to be clear that I'm only representing my perspective on, what I've actually accomplished. Some of it was done in this job, some of it was in a previous job, and anything, it's not meant to be read as a political endorsement or a partisan kind of discussion. It's just giving you guys examples of things that I've actually been able to accomplish in the hopes of kind of teaching some advocacy skills. So just keep that in mind. Next slide, please. So what we're going to talk about today is what is policy advocacy? What tools can I use to make change? And what are some examples of policy advocacy that succeeded, or at least partially succeeded? This is not going to be a comprehensive list of the tools you can use to make change. That would take many more webinars, but I do kind of have some lists. And then, as I said, I will be using some examples. Next slide. Sorry, I have to change my screen a little bit. My screen is blocking. Okay, here we go. So I started with a quote from someone that I work with and respect, because I just thought it was a good way to center the specifics we're going to be talking about in the context of racial equity and health equity. So the quote is from Karen Savage Sangwan, who's the executive director of the California Pan-Ethnic Health Network. They are one of our colleagues that works to make sure that issues of health equity and multiculturalism are infused throughout California's move to make sure everybody has good health coverage and access. And Karen said, only through the radical reimagining of our healthcare system and the explicit pursuit of anti-racist policy and systems changes can we achieve health equity. Health equity means that everyone has a fair and just opportunity to be healthier. Health inequity indicates differences in health outcomes that are systemic, avoidable, and unjust. So that, I thought she just did a really good job of summing up kind of what I hope a lot of my work has been about. And I'm hoping work that as you go on in your professional lives, that you will in some way contribute to. I really strongly believe that while there are people like me who are paid to work almost full time on health equity issues, providers and academics have a huge role to play as well. As I'll talk about later, nothing is done without a large coalition. And students and practitioners have been a really important part of getting things done that I believe have helped achieve or move towards health equity. We certainly have not achieved it yet. Next slide. So I just wanted to briefly mention, and most of you probably know this, individual advocacy versus policy advocacy. So the word advocacy just means to taking action, speaking and acting on behalf of yourself or someone else. Individual advocacy is very important, but it's not the topic for today. So individual advocacy, for example, might mean you realize that a client of yours does not understand the treatment plan for their healthcare because of language barriers. You arrange with the health clinic for them to have an interpreter present at their appointments and for their medication instructions to be written in their native language. So that would be individual advocacy. You are helping out an individual client of yours. Next slide. Policy advocacy is an activity that aims to influence decisions within political, economic, and social institutions. You are trying to change the systems in order to solve the problem for more than one person. For example, using the previous client problem, you might join a coalition like the California Pan-Ethnic Health Network that asks the state legislature to pass legislation saying that health plans must have providers who speak the area's threshold languages or must provide translators and instructions in those languages. So this has actually happened in California. California has legislation and regulations that implement the legislation that require translation. The implementation of that issue has long been difficult, and the legislation has been amended several times. For example, there's been a lot of controversy about whether or not it's okay to have a family member be the interpreter for the client. So there's been a lot of issues about this, but at least in California, there were so many individual instances where people really couldn't understand what their health plan was and really therefore couldn't help make decisions that led to a big emphasis on making sure that people had the opportunity to understand what was going on in their native language. Next slide. So implementation, I put where the rubber meets the road. One of the things that can be really complicated with policy advocacy is sometimes it starts with legislation. And people think, well, we got this piece of legislation passed, the governor signed it, it's in law, our job is done. And what all of us who have worked on policy advocacy have realized is that it's nowhere near done at that point. Legislation in some way holds up an ideal of what we think should happen. And even though we may have made many compromises to get to the point where legislation is passed and implemented, is passed, the implementation is often one of the stickiest points. So if you are a policy advocate, one of the things you'll need to do after you achieve a policy win is often monitoring and critiquing and advocating for it to be implemented correctly. The other thing you have to do is to try to get the appropriate government agency to enforce whatever the legislation says. So as I mentioned, there are many laws now on the books about translation, but it's pretty common for people to still have problems. And if those problems are, people need to know where to report those problems. And then advocates need to know how to continue to advocate to either go back and amend the legislation, to have stronger regulations, or just to have whatever agency is in charge enforce the regulations. However, in order to do that, regular people need to know what the regulations or legislation are. So you may see, for example, in workers' rights, there's been a lot of legislation that included the fact that a workplace must post rules so that in a place that a lot of the workers go, so that if you walk into the lunchroom, for example, of a lot of agencies, you'll see big posters that say, here's the minimum wage, here's your right to complain, here's what to do if something is going on that shouldn't be going on. But that there are many ways that that is actually a very complicated step. So just to give you an example, I was part of a program in San Francisco that provides access, not health insurance coverage, but access to people who are otherwise ineligible for health coverage, particularly for Medi-Cal. And I'm going to talk about that a little more later. And while we are very much in the midst of changing Medi-Cal law so that everybody is covered regardless of immigration status, in the meantime, about 10 years ago, San Francisco created an access program where at least people could have a card, they would know where to go, and they would use the system of public and private health clinics and the San Francisco General Hospital to get their care. It's been a very successful program called Healthy San Francisco. Part of the way Healthy San Francisco was funded was all the employers who had over, like, I think 20 people in their employment had to either provide health insurance, pay for the Healthy San Francisco program, or have a fund for their workers that they could use to pay health costs. It was called the HCSO, Healthcare Security Ordinance. And it turned out that a lot of the people who had opposed this policy change, one example is that many of them were restaurant owners. So the Golden Gate Restaurant Association was the biggest organized opposition to this bill. The restaurant workers employed a lot of undocumented people, and this bill was in some ways targeted to help people who just, for example, might be a dishwasher in the back room of a popular restaurant, but not have any healthcare coverage. And the healthcare security ordinance required the employer to post the rules about this program and their right to health access in their place of employment. But when we saw that very few people were taking advantage of this program, it turned out they were mostly just posting those signs in English. And many of the people most affected by this potential route to health access did not speak any English. As you, I'm sure, know, that many people who come to this country end up taking restaurant jobs because in San Francisco they're plentiful. While they don't pay very well, until COVID at least, there was a lot of them. So a lot of people end up doing that as their first job in this country, but they don't necessarily have the English skills to read a complicated posting about legislation, about a right that they have. And the employers aren't necessarily going to advertise it because they don't really want to pay out for this program. So that's an implementation issue that we had to deal with after the legislation was passed. Another implementation issue was that some restaurants, and this was legal, put on their receipt, they would add a charge. You may have seen this if you've gone out to dinner in San Francisco that says, this is a healthcare charge that is related to the healthcare security ordinance. And that's perfectly fine to charge people more and explain why. But it turned out that the money they were collecting from that charge was not all going to the workers. So in many cases it was, but there were many large restaurants, including some of the kind of finest dining establishments, that were not actually using all that money to go towards their workers. So in order to, there's, as I mentioned, there's many ways to try to get implementation done in the right way. You could try to change the legislation, you could change the regulations, You can try to get someone to enforce the rules that are in place. If you get desperate, you might ask a public interest legal organization to see if litigation is appropriate. So that's when a public interest law firm, such as, let's say, the Youth Law Center, brings a class action suit to say, you know, this problem has adversely affected a large class of people, and we're going to sue on their behalf. And then one of the most important and often overlooked things is you might help spread the word that a new program has been created and help people know their rights. So if people don't realize that there is this health access program and that their employer has money for them set aside to use it, it's not really that helpful. If people don't know that undocumented children are now eligible for Medi-Cal, and the parents don't take the child to sign them up and do some paperwork, if they don't know, even maybe they do know that they're eligible, but they don't know how to go about signing up, they need to know where they can go, and they need to know where they can go to have someone speak in their language. So a lot of the work that the clinics have done about covering undocumented people has to do with not only passing the law, but really making sure at the grassroots level and in the correct languages that people know about it and also know where they can go to get help. Next slide. So I just want to briefly go through some tools. As I said, this is not all the tools. But these are some of the things off the top of my head. I was like, what have we done to get some successes that we've had? One of the things is just the basic distribution of public education materials, such as fact sheets. So the first thing you often want both the public and policymakers to know is just what's the problem and how is your solution going to help? So for example, in the context of expanding healthcare coverage for people without documentation status, you know, we distributed a lot of material that kind of said, this is how many people it affects. This is how many children it affects. This is how many seniors it affects. We also distributed fact sheets and found research and tried to summarize research that explained why it was cost effective to actually give people health insurance up front, as opposed to, waiting till they could be served in the emergency room. You can do social media campaigns. You can do letter, telephone, or email campaigns where people let their legislators know what they think about a subject, what the problem is, what the potential solution is. You can, although I personally have never worked anywhere that had the funds to do this, you can do paid advertising. So you can do targeted ads towards whatever group you're trying to reach, that you pay a newspaper or in most cases now a social media site to run an ad that explains what you're doing and why. And sometimes the paid advertising will not be directly, hey, vote for this bill, but will be background information to kind of set the tone for a policy debate. So the California Endowment, which has funded a lot of the work of me and my colleagues, did a big campaign where they just showed kind of a diverse range of people and wrote health coverage is for all, or just health for all, just to kind of set the stage that this is something that we're going to be working on. If you work for a nonprofit, a lot of what you end up doing is what's called earned media. And what that means is you try to not pay for advertising, but to get reporters or editorial boards to write about what you're doing. I also have done quite a bit of radio because there's enough radio shows locally that it's not that hard to get on a radio show. And a lot of what I've done is to, present an issue. There'll often be someone who presents a counterpoint to the issue. And then I've had several situations where callers were invited to call in and give their opinion. That can be kind of tough because sometimes the callers who who call are kind of at the extreme end of a position on something. And so you're not prepared necessarily when they call in and attack you personally, but I've kind of gotten used to it. And then you can do legislative briefings, visits, or town halls. So we have a day at the state capitol where CPCA members, California Primary Care Association, our statewide association that I work with a lot, we have a day where we go and we have booths that, you know, give out health information. We have a coffee cart for legislative staff where they can get free coffee. And then we all separate into our groups and walk around to whoever the legislature is, that legislators that represent our region. And we talk to them about our specific issues. We also sometimes have a rally where we just have a, you know, inspirational speaker that talks about the issues in the broad sense. The advantage of this kind of statewide day or two of focused advocacy is just that it kind of calls the legislators' attention to the fact that it's not just their district or their constituency that is caring about this issue, but that there's a larger constituency that cares about it as well. We do the same thing, or did before COVID, at the national level, where National Association of Community Health Centers holds a conference and a day on the Hill in which we fan out and have appointments with our local legislators. And we mostly, when we do that with Congress or with senators, we really focus on families, on patient stories. So we bring staff and patients from our clinics, and we may introduce a topic like healthcare funding, but then the patient or this talks about how the use of a free clinic has helped them. And a staff member will often talk about an issue like how to work on the behavioral health crisis and why we need more funding for medication-assisted therapy, for example. And the stories are often the thing that kind of feel like you really kind of get to the legislator. And then, of course, you have to follow up with whatever policy proposals you are seeking to pass. Next slide. So I just want to mention this briefly. There's a lot of confusion in the nonprofit world about advocacy versus lobbying. Just to be clear, and I talk about this everywhere I can because people are confused about it. It's confusing, but there's a kind of mythology out there that nonprofits cannot do lobbying. And according to IRS rules, if you're a 501(c), which is a standard nonprofit organization like the San Francisco Community Clinic Consortium, you can do lobbying, but it has to be an incremental amount of your work. So you cannot have a large percentage of your resources going to lobbying. There is a way that you can kind of protect yourself and file something called a 501(c)(h), which basically says we're going to spend up to 15% of our resources on lobbying. What really limits nonprofits is not so much the lobbying laws from the IRS, but funders are often very strict about lobbying. So for example, much of my work for the past 20 years in different jobs has been funded by the California Endowment. And because they are a certain type of foundation, they have to put in their funding agreement when they give us a grant that we can't use any of their funds to do direct lobbying. So, and I'm going to get to in a minute what the difference is between advocacy and lobbying, but I actually spend very little of my time doing direct lobbying, but I do spend some of it. So for example, when I go on these day trips to Sacramento or to Washington, DC, and I'm visiting legislators and in many cases asking them directly, please vote on this bill, or this is why we're in favor of this bill. We keep track of that on my timesheet and we pay for that funding through unrestricted funds. So in our case, we have an annual gala, for example, and we get a small number of individual contributions. So it's really funding restrictions as well as kind of a fear of lobbying that often limits people. Also, when you have federal funds, so we, what pays for a lot of the expenses of my office, although not my work directly, is a federal healthcare for the homeless grant. We're not allowed to use any of those funds for lobbying either. And so what I put on here is, well, all lobbying is advocacy, not all advocacy is lobbying. So advocacy is broad, as I mentioned before. Direct lobbying is just when you're literally asking a legislator or an elected official of any type to vote a certain way about legislation. So if I'm sitting in Scott Wiener's office and I'm saying to him, please sponsor bill number 431, and this is why it's going to help the health centers, and we know you support health centers, that 20 minutes that I'm sitting in front of him is direct lobbying. There's also something called grassroots lobbying, which has even further restrictions. And grassroots lobbying is when, let's say I send out an email to all of my clinics saying, come join me in asking Senator Scott Wiener to vote yes on Bill 431. That's considered grassroots advocacy. There's a lot of debates about whether budget issues are or are not lobbying. It's a complicated thing, and there's a nonprofit called the Alliance for Justice that goes into great detail about this. So you can go to their website to find out more. But I just want to be clear that if you're representing an institution or your funding is such that you feel like you cannot do advocacy, you cannot do lobbying, I'm sorry. If you can't do lobbying, you could still do other forms of advocacy. I just want to be really clear about that and not have people be too scared to go directly to their elected officials. Next slide. So just for some kind of, basic stuff, while we may only be spending 20 minutes in a visit with a policymaker, decision maker, elected official, we really spend a lot of time planning those 20 minutes. A lot of the work goes into the preparation, not so much the actual meeting. So the first thing that we really try to do is just connect. So just for example, in my Scott Wiener example, I would say, hi, Scott, you might remember me from our work together on this bill. I work for SFCCC, and I'm also a constituent of yours. And this may not be all one person doing this. Often I'll bring, 8 people, and I'll do the initial connect and the elevator pitch, and then other people will talk about the other things I've outlined here. So the connection is often a personal connection. You might have a situation where, let's say you're lobbying for hospice care for children. You might have someone who says the connection might be, hey, I'm a mother of a child who has cancer, and this is why I really need you to support, this bill that allows for pediatric hospice care. Then there's the elevator pitch. The elevator pitch just means in 30 seconds, what are you trying to get done? And it's really just a summary. Often the pitch is communicated to a legislator's staff member before you get in the room so that they've already prepped their elected official, but you still usually repeat what your ask is. And then we might have individuals impacted by the issue explain why it matters to them. This is what happened to me when I went into the clinic and I didn't have an interpreter. You want to explain who would be helped by this change, how many people, or what type of people, or why is it particularly important for this district that this legislature represents? Why should they care about this issue? This can be either depending on the legislature, it can be appeal to their morality, it could be appeal to their budget sense. If it's something like healthcare for children, insurance coverage for children that actually saves money in the long run. But you really want to give them a very concrete reason to care about this issue. You want to give some data, often because data is so hard to explain in a brief presentation. We often do that in a leave behind. So you might have a written fact sheet, which a lot of data, and maybe you'll mention the data in the conversation, but then leave the fact sheet with the person's staff so that if they do want to support your cause, they have something to back it up. Some people believe that you should, especially when talking about a controversial issue, actually talk about what the opposition is. And this is really a judgment call. So in some cases, when you know the opposition is going to be loud, you might want to mention some arguments against this are, and then you really emphasize the arguments in favor. So for example, during the argument about children's health insurance coverage, sometimes you would hear, well, and I don't believe in this, but this is what I'd hear from more conservative legislators. I'd hear, well, these people are undocumented. Why should they get health coverage paid for by taxpayers? And we would explain then, originally when we were working on children's health insurance coverage, why it was cheaper to insure children's health up front. We would talk about how they were often, brought to this country as children. And we would explain that a lot of immigrants, both documented and undocumented, are working in California. So they're the same people who are preparing your food or driving your Uber. These are people that we all deal with in everyday life. Then you ask them directly for something. So sometimes it could just be, will you support this issue as we launch this campaign? Or, and this has to be done by someone who can do lobbying, it would be a direct ask. Please support Bill 431 for all the reasons we've just discussed. And then the follow-up. The follow-up is really important. And sometimes I feel like this is the area I do the least well on. But after you've made this pitch, and usually you have a very short time to make it, and a lot of people want to speak, the job of who's ever leading this delegation is to follow up. So in a week or two, particularly if you don't get a positive pledge right there to endorse your issue, which sometimes I get, a week or two later, you call the legislative staff person and say, hey, has Senator Wiener had time to think about this issue? Does he have any concerns, or is he able to give his support? And if the staff person says, oh no, he supports your issue, you want to say, well, would he speak up about it during a committee hearing, or whatever you think will support your point of view? So the follow-up is critically important and often takes several different steps. Next slide. So what are we up against? This is just really basic, but I just got a time check. Okay, so what are we up against? We're up against, we're trying to, in health equity lobbying advocacy, we're really trying to change big upstream factors. And these factors impact millions of people. So it's just a note that if you are going to be engaged in advocacy, either as a professional, full-time professional like me, or just as a provider, where you sometimes might really want to go to bat for something in the system that you see doesn't make sense, you are going to be coming up against powerful interest groups determined to resist change. And again, I can't emphasize enough how much professionals who can give an example from their own work, as well as people who are directly impacted, can change or at least go up against the powerful interest group. So I'll give you an example. I once went with a group of residents from San Francisco General, as well as a group of parents of special needs children, to talk to the SF Chronicle editorial board, because we were trying to get rid of co-pays for children in Medi-Cal. And they must have had a visitor from somebody on the other side the week before, because they came up with all these statistics, which was hard for us to refute because we hadn't seen them in advance. All these statistics about why asking people for like a $5 copay was not a bad idea. And then the resident who I was with said, let me give you an example of a family I saw last week. And she gave an example of a family who had come on the bus and it was hard for them to come up with the bus fare. And even though they only had an appointment for one child, they brought all 5 of their children with them to the pediatric clinic. And the pediatric resident was determined to see all 5 of these children to get them up to date in their immunizations and find out about any health problems, because she knew that they wouldn't be able to come back. And she talked about how if there was a $5 copay per child, that parent really may not have been able to afford that visit. So that did seem to have an influence on the editorial board. Next slide. So I'm going to give 2 examples. I might have to speed up a bit, but I'll give one that's very specific and might be close to home for some of you. So in the community clinics, we make most of our money through Medi-Cal. And for a long time, for behavioral health visits, which have become a bigger and bigger part of our work, along with primary health care, for a long time, the only people who could bill were psychiatrists, who we don't have because we can't afford them, psychologists, we have only a few of them, licensed social workers. Those are who we could bill for. And as MFT programs became more popular, we realized this was another group of people that could potentially help at our health clinics and had a more diverse representation. So I don't know if this is still true, but when we started doing this work about 5 or 10 years ago, MFTs in general were more language and culturally diverse than LCSWs. And so we had to really lobby hard to say, we want MFTs to be billable providers. And we sort of won this fight. Oh, can you go to the next slide? We sort of won this fight in that MFTs did become billable providers, but the way the legislation was written made it very complicated for a clinic to change their billing practices. I won't go into the gory details, but there's something called the PPS rate, and you have to have a scope. And they basically said you have to change your scope to include MFTs. So in reality, to date, not that many MFTs can actually be billed for. It doesn't mean they can't work at a health center, but it means the health center will have to cover their salary somehow somewhere else besides Medi-Cal. And we are very much working to change that in the context of Cal-AIM, which is a way to reform Medi-Cal, and an alternative payment methodology, which is a way to start looking, instead of at face-to-face visits, looking at all the things you do for a patient and not having to count each visit specially. So this may be resolved, but it was just a disappointing thing that we took a long time. The regulations took forever to issue, and now my clinics are telling me the regulations are so complex that they're not sure they can actually implement them. So that's my very specific piece of legislation and regulation. And then real briefly, next slide. I want to talk about the biggest thing I've worked on personally, which is the 100% campaign. So for many years, I was the policy director at the Children's Defense Fund, which is a national organization, but I ran the state office. And with the sponsorship of the California Endowment financially, a bunch of children's organizations got together and said, we're going to get every child in California eligible for health coverage. That meant in some cases, children who were over income for Medi-Cal, but their parents were not wealthy enough to buy health insurance outright. And then in the majority of the people we're advocating for were undocumented immigrants or immigrants without sufficient legal status to get Medi-Cal. We began with a local pilot called the Children's Health Initiative in Santa Clara County, where a group of people got together and got a program for children's health coverage, but just in Santa Clara County. Eventually 30 counties, including San Francisco, had this program. And then with the endowment support, we launched the 100% campaign to try to get it for all children. Next slide. Oh, and I think I put on the previous slide, 18 years. It took 18 years to get it done. So we used all the techniques that I mentioned earlier. We published a roadmap, which we called a strategic audit of the situation. We did administrative advocacy to reduce what was then a 28-page application, just so more kids could get on. We did research, we commissioned research from an academic institution to talk about the costs of children falling on and off Medi-Cal. We broadened our coalition to include faith-based groups, business-affiliated groups, medical students, residents and teachers association. We ran legislation several times that passed the legislature, but was vetoed by several governors. We did a ballot initiative, which narrowly failed. We tried to put our children's health coverage policy into Governor Schwarzenegger's attempt at California healthcare reform, but the overall attempt failed. We did a lot of media, public education, and we held rallies in Sacramento with people from throughout the state. Next slide. So I'm just going to really briefly, I did not come up with these, but I found these last night when I was looking through my old documents, and I thought this was really interesting. These lessons learned actually comes from Bob Brownstein, who helped start the first local children's health initiative that our statewide program was later based on. And so I won't go through them all because we don't have enough time, but it is, if you have time to look at the slides later, I thought some of the things he had to say were really interesting. Next slide. Next slide. That might be the end. Okay, so real briefly, I just want to say, and I meant to have a slide on this, that the 100% campaign ultimately succeeded. And not only did it succeed in getting all children covered, it is now brought in to be something called Healthcare for All that many institutions are working on and that the clinics are very much supporting, which is going to cover undocumented adults with Medi-Cal if they're income eligible. It's very expensive. Children are cheap to cover because really children are rarely hospitalized and preventive care is pretty cheap, but adults are more expensive. So in this last year's state budget, we got the first piece, which is covering adults over age 55. And I'm blanking on the number, but young adults are covered up to a certain age. And so I think what's left is the cohort between 26 and 55, which is big, but it just shows tremendous progress from the beginning of this program. We're walking around and people are saying, you know, we're not going to use taxpayer dollars to cover undocumented immigrants, to pretty much agreement in the legislature that this should be done. And the issue is all about finding the money. So that's a lot, I know. So I'm now open for questions.
Thank you so much, Deena, for all of that terrific in-depth information about advocacy and policy. I do actually have one question right here. How can frontline clinicians support policy advancements and change?
Well, that's a great question. So, I mean, one thing you can do, because you're all really busy, is work with whatever your state or national association is. So just for example, we had a lot of pediatricians supporting the Children's Health Insurance Covered Initiative for obvious reasons. And so we actually brought into our coalition the California branch of the American Academy of Pediatrics. And when we were doing something like going to an editorial board or holding a rally, we would ask pediatricians, or in many cases, pediatric residents, to come and wear their white coats, even though pediatricians mostly don't wear white coats, but we would get the visual of them in the white coat. So, you know, often I know that, just for example, the National Association of Social Workers, and I'm sure there's an equivalent MFT, will take positions that are, you know, essentially advocacy positions. The other way you can do it is by staying in touch with a more local. So those are kind of like the more formal things you can do. Also, as a clinician, you can actually influence your association to support or oppose legislation. And that's often really important. On a more local level, there are grassroots branches of advocacy organization. In many cases, we worked really closely in the 100% campaign with PICO, California, which happens to be a faith-based organization. So they organize in churches and synagogues and mosques throughout the state. And they were super important because they were in counties that aren't, or areas that are not necessarily the ones the legislators are used to hearing from. So, you know, LA, San Francisco, they roll their eyes. Yeah, you liberals are coming again, whatever. But they had people from Fresno and from Stockton who in a very nonpartisan way would say, look, I need this. You know, I run a small business and I don't have the money to cover my workers and they need this. So connecting with a grassroots organization is often another really good way. And if you want to know who's working on an issue, if you do a Google search in your local newspaper or online advocacy, you will often see who's talking about this. You know, what's the name of the people? What's the name? And you can connect with them. I know I love it when I've had students, for example, call me and say, hey, I really want to work on this. Can you tell me how? And either I'll have a direct assignment, like write a letter about a situation you encountered professionally, or I will at least connect them to something ongoing where they'll get emails or access to a website that can tell them what to do. I really do encourage all of you to join whatever association. I mean, the associations in some ways sometimes have a bad name because they were, like the CMA sometimes gets a bad name because they were organized to protect the interests of doctors as opposed to their patients. But there have been several breakout groups within the CMA that have really pushed to, you know, include some of these issues that maybe don't raise doctors' salaries, but are good for the healthcare system as all. And then there's often, for example, there's an organization called Physicians for Social Responsibility that take a different point of view from their professional association. I don't know what the association is called for MFTs. Do you know that, Julie? But I'm sure there is one.
Yeah, so it's California Association for MFT, CAMF. And so, yeah, and also just to advocate for the Association for LPCC as well.
Yes.
I know you're fighting for MFT, but I'm going to get that in as well as you continue on with advocacy to fight for the LPCC.
Yes, and we are actually very interested in doing something about that next year.
Yeah, no, thank you for your work on that. We have another question. So dealing with advocacy burnout. You know, and you think about our clinicians, and this is my own comment on it, there's burnout happening already. And the need for advocacy today, I think continues to be so important for our clinicians and our counselors. But any tips about how to manage that and to continue to persevere and persist with being an advocate?
Well, here's what I would say, you know, even if you don't have a lot of time, doing one thing is often enough. I also have talked to a lot of clinicians who have said sometimes in their work, while they love their work directly with clients, they get very frustrated because they see how the systemic barriers that support income inequality and health inequality are affecting their patients. And so they sometimes then say it's a relief to spend, maybe it's 10 minutes a month, on doing something, whether it's writing a letter, sending an email, writing an article in your local newspaper, joining a listserv and clicking on tell my story, even if it's a very small amount of time, that it actually helps them moderate their frustration with the system. I also know clinicians of all types who are like, there's nothing we can do about the system. It's so horrible. And, you know, obviously I don't believe that, or I wouldn't be in this line of work. And I have seen things change. I just think things take a lot longer than you would want. So I think it's a different kind of burnout. You know, the burnout that you experience as professionals who are, you know, often holding people's pain and struggles. And that's really distressing. And then the burnout as an advocate could be, why do I have to even argue about something as basic as everybody should have healthcare? But if you balance the two, I actually think it can help you with burnout.
Yeah, I appreciate that answer, because particularly in the counseling discipline, advocacy is taught, you know, it's up there with the actual counseling and case management work. So this is a competency that our counselors are learning and enacting. And on the one hand, I appreciate that comment about wow, it could actually help you feel like you're doing something for the very system that you're frustrated with. I think at the same token, I think I really like your suggestion around don't take on too much,
Right.
do something. So you don't get caught up in that sense of like, oh my God, I'm banging my head against a wall, you know?
And really don't underestimate how a clinician can have an impact. I mean, when we, like I said, advocates, professional advocates have a bad name, rightly or wrongly. You know, they lump us in with all the other advocates, even though a friend of mine who runs Children Now, a big children's advocacy organization, said, how come the people who represent big oil aren't ashamed to ask for what they want? We should not be ashamed. That's all true. But I actually think if you go and you say, I'm a nurse, I'm a counselor, I'm, a social worker, I'm an MFT, and here's what I saw, you will get a lot more credibility than the professional advocates. So you should use the professional advocacy organizations to give you the materials, set up the appointments for you, explain to you how you write an op-ed, but then your story will actually be the thing that matters.
Mm-hmm. So I have 2 more questions and we have 4 minutes left.
Uh-oh.
So how would you recommend we bring in patient/client voices for advocacy in an effective and ethical manner?
Now that is like the $10 million question. I'm not sure I could answer it in 4 minutes, but I'll try. We have really struggled with this because a lot of my work has been expanding health coverage for undocumented people. We had to be really careful not to expose them to anything that would endanger their status or even, bring negative publicity. Health Access California, which has a great website, does have a story collection project. And I believe that they take away any individual identifying information, but still tell the stories of their patients. We often, we have had some people who, even as undocumented immigrants, were willing to walk around and go to Dianne Feinstein's office and explain their own story. But we've had other cases where, as I said, like a pediatric intern would explain what a family had gone through without actually putting the family themselves forward. So there's a lot more I could say on this, but I really, I recommend you look at the Health Access website because they have a whole story project and they'll explain how they're doing that.
Yeah, maybe we can find that and put that in the chat for everyone. Okay, I have another. The role of advocate within these larger systems seems complex. Did you learn these skills, techniques on the job, or were there mentors or trainings you received to assist you learning how to get your message out?
A combination. I mostly learned on the job. And, one of the things is that I actually began my career. Well, I did some direct service for a few years, and then I worked in New York City government. It was all happenstance. I was very young, but I ended up working for a very progressive mayor, and I ended up working on a lot of Medicaid issues in New York State and New York City. And I got no formal training at all. But what I learned from that was how the people who are constructing the budget, let's say, think about these issues. So that was super important to know how, know the other side, not see the people in the budget office as evil or unnecessary, but they're going to always be worried about the costs. And then a lot of what I learned was definitely on the job. I mean, I did have some formal media training, which is excellent if you can get it. Foundations often supply, media training or training on how to create an advocacy material. But I will have to say, almost all of mine was done. When I worked at the Children's Defense Fund, there were many senior people who had already been through this fight in New York State, and we were now doing it in California. And I talked to them all the time and asked advice.
Thank you. All right, we're down to our last 30 or 40 seconds, but I would just if we all need to go fight for a new policy or a policy that's in grow, what would you suggest? What are some really pressing issues that we can spread the word about, whether it's new programs or new policies? Anything that you would leave us
definitely with? Health for all. And if you even look up hashtag health for all, you'll see, as I mentioned in May, it was in the last budget, but it's not going to happen until May. Medi-Cal coverage will be expanded to certain groups of adults, but we are very much working to get everybody covered. Because while health insurance coverage is not the answer, it's like the first step. It's necessary, but not sufficient. So if everybody has coverage, there'll be more people who have access to services. And I just, you all know this already, but I'll just say it out loud. Our clinics are seeing a dramatic increase in the number of people who need behavioral health services. And so advocating for certain policies like allowing telehealth to continue turns out to really be helpful in terms of getting low-income people access to these services. We found that a lot of people who hadn't been willing to come in or couldn't, they couldn't take time off work, they don't have flexible jobs, we're much more willing to talk with a behavioral health person on the phone. So we're going to be advocating. We have that ability to build for telephone services for the next year, but we're in the midst of advocating it for it to be longer. I have a blog. I have not been very good at keeping up on it, but I'm going to get better. So if you want to look at some of my issues, it's www.sfccc.org. I think it's on one of the slides, and I'll highlight certain advocacy issues.
Okay, Deena, we can't thank you enough
Thank you
for this knowledge and great information. I encourage everybody, if you have more specific questions that you'd like to ask Deena, it sounds like you're willing to answer them offline. So
definitely.
Email is available in the chat, and we thank you so much for all your support of our project.
Thank you very much.
Thanks, everyone.